Hello, everyone. Thank you for attending today's webinar, Using Genetic Services to Improve Each Aspect of Your Quadruple Aim Goals, presented by Genome Medical. I'm Rebecca Kushmiter, and I'll be moderating this webinar. Our speakers today are Steve Blyle, Chief Medical Officer at Genome Medical, Colleen Kaleshu, Senior Director of Clinical Research at Genome Medical, and Molly McGinnis, Senior Director, Client and Partner Relations, Population Genomics at Genome Medical. You can read their full bios on the left side of your window by selecting the Speakers tab. Just a few technical notes before we begin. The webcast is being streamed through your computer, so there's no dial-in number. For the best audio quality, please make sure your volume is up. The webinar is being recorded and it will be available on demand within 24 hours after the event. Time permitting, we'll follow the presentation with a Q&A session. Please submit your questions using the Questions and Answers tab on the left side of your screen. All right, now let's begin. Steve, please go ahead.
Hi, and thanks. I'd like to first thank Fierce Healthcare for putting this together and everyone for coming. So my job is to kind of set the stage for what might seem like a bit of a provocative title for those of you that are familiar with the Quadruple Aim, which was introduced really to under one premise to really bend the cost curve of healthcare back in the early 2000s. And when you mention genetics and genomics, I think we get asked a lot of times, isn't genetics expensive? Isn't genomic testing really pricey? And isn't it really just applicable to only a few of our patients? Is it really something that's right for the whole population? And finally, it's complicated and difficult for providers to stay abreast of, and sometimes confusing for patients. So we obviously are committed to this goal, and we're going to take each of those in turn head on. But I wanted to start off with a concept that's embedded in this Quadruple Aim. And those of you that are familiar with the aim would probably recognize a figure like this, where really implicit in bending that cost curve is the need to move the care we provide earlier in a patient's trajectory. So either at the at-risk stage or early in disease, rather than in the chronic disease stage or end-of-life care. And in doing so, we're really able to personalize that care, to improve outcomes, and to really bend the cost curve towards higher value. And we believe that genomics is uniquely powered to do that. It really allows us to put the patient at the center, to identify those who really need surveillance, to really intervene early in a disease process, and be proactive about healthcare rather than reactive. So genomics really presents us with a great opportunity. And that opportunity is actually growing rapidly, driven by several factors. The first is an amazing progression in the technology underlying the sequencing. So I was just at a meeting where we learned that the cost to do a whole genome has now broken the $100 barrier with one technology. So as these costs continue to drop and roll out into clinical tests, that really drives the next box here, which is indications are expanding quickly and reimbursements improving. So the ability to do sequencing at a much lower cost, and our knowledge growing at a rapid pace on which patients can benefit is really driving both the accessibility to patients and the reimbursement. And then finally, not really listed here, the other exciting thing that's really growing quickly is the treatments that are available for this. Finally, that last box just mentions that this is not new. Genomics has really been rolled out by several systems to great effect, and there's some best practices that can be applied as we go forward. There's a but slide here, though, and that is that despite the opportunity, we still struggle to seize it. And even for some of the best known use cases like hereditary breast and ovarian, where we're rolling up on the 30th anniversary of the discovery of the BRCA1 gene, fewer than 1 in 5 people were actually getting this test that met guidelines back in 2017. And I don't think we've made a ton of progress on that. And those guidelines themselves tend to progress very slowly. And studies have shown that they only recommend testing for patients about of which 50% of would have the mutation. So we're only detecting 50% of the patients that could benefit. These challenges are really driven by a couple things. First is access. The workforce in genomics and genetics has really been understaffed. Those with expertise in genetics really are not well covered in the country. The second is that rapid change I talk about. The the knowledge about genetics, the shifting guidelines are really difficult for clinicians to stay abreast of if they're even aware of them. So, that ever changing expertise is also in short supply. And finally, is I mentioned decreased cost of sequencing, but what about the cost for the treatments and the surveillance that go along with it? And all of this has led to some uncertainty around the financial models in most health systems. So who are we? Genome Medical, we were really created to try and solve some of those challenges. We combined a 50-state national telemedicine network of clinicians with technologies that help improve the efficiency and effectiveness of genetic care. We have a large insurance base, and our clinicians are really able to cover any area of clinical genetics and genomics that you'd encounter. We do fill that services gap through a telemedicine network, and we fill the expertise. We really help you identify the patient that can best benefit from genetic consultation and testing if indicated, and then really follow up on what is the right care for that patient. We also offer a genetic advisory services that help systems really benefit from those best practices that have gone before so that they can build programs in their own systems. So I'll pass over to my colleagues here shortly, but I just wanted to mention that we're going to use examples from the best known use cases in genetics to kind of support genomics use to meet the quadruple aims. But most of these will be in the best known areas like cancer, where really genomics plays a role all across the care pathway, from risk assessment, early detection, treatment in a targeted way, and monitoring for recurrence. But there is really low-hanging fruit in every clinical area of medicine today. A few others are listed here, including reproductive health and pharmacogenomics, where I think most of us understand we haven't really solved the adverse reaction rate and lack of failure for many medications. Lastly, I just want to mention the exciting progress in rare disease, which we're not going to talk too much about today, but really, we talk about rare disease as if it really, this only affects a few of our patients, but more and more genetics and genomics affects all of us. And rare disease itself, while individually rare, really makes up about 10% of, explains issues for 10% of us. And it's not just a diagnose. We're really getting to specific and really highly effective, if not cures, for some of these rare diseases, which have been rolling out at an astonishing pace, and there's about 1,000 of them in the pipeline. So this is becoming more and more of a priority for us and health systems we talk to. So I will now pass it on to Colleen Kalashu, who will proceed with some of these goals.
Thanks, Steve. You set up this section really well, in particular talking about how we can use genomics for cancer care and how far behind we are on even the very well-established hereditary cancers like breast and ovarian cancer. So, of course, one of the quad aims is to improve population health, and I am going to be speaking specifically about cancer. Cancer has long been a disease that we focus on in population health, whether that's through cancer screening or other methods. So how can we use genomics to improve population health in terms of cancer specifically? Well, as Steve mentioned, genetic disease is no longer something we think of as rare, and that is especially true for hereditary cancer risk. So what I'm going to go through today is the notion of using risk of hereditary cancer to stratify the population and make tailored cancer screening and prevention plans. And in order for that to have an impact at a population health level, hereditary cancer predisposition has to be sufficiently common. Well, what we've seen in recent studies is that if we take 8% of all of us on this call, 8% of people in a grocery store, just whoever, 8% of 8% of individuals have a genetic mutation that predisposes to cancer. So this is not uncommon. If we look at it instead from the perspective of cancer cases, what portion of them are due to a genetic mutation that predisposes to cancer? Depending on the specific cancer site, it's anywhere from 10 to 25%. So This is not a rare risk factor and is something we can use for population risk stratification. So once we can identify the individuals in the population who have a hereditary risk for cancer, there are very specific things that are guideline based, these are here and now, that can be done for those individuals. They can get a tailored cancer screening plan that involves more screening modalities, starting screening at a younger age, increased frequency. They can also get risk-reducing surgeries. For example, risk-reducing bilateral mastectomy has a 90% effectiveness or reduces the risk of breast cancer by 90%. So that's quite significant. For individuals who do go on to develop cancer, this can also inform their cancer treatment. When someone does develop cancer, and it's because of hereditary cancer risk, their treatment, not only their treatment, but also their clinical outcomes differ depending on whether that mutation that's causing their cancer was found before their cancer diagnosis or after their cancer diagnosis. So this is a recent study that compared patients who had those differing timings of identifying their cancer, their mutation that drove their cancer, and individuals who had their hereditary cancer risk found in advance of developing cancer. Their cancer was less advanced, and most importantly, they had a better 5-year survival rate. So this is clearly of such benefit to stratify the population based on hereditary cancer risk that it is something that the U.S. Preventive Task Force recommends that primary care providers do. The American College of Obstetrics and Gynecologists recommend that OB-GYNs do it, and the state of Nevada has even legally mandated it for primary care providers. The trouble is it's not happening, and it's not happening because it's incredibly complicated. The guidelines are constantly changing, and it's very time consuming. These are two different studies covering two different time periods, and they both found that individuals are only being informed of their need for cancer genetic testing, only about 20% of them. And that's even happening now, even at places like the Cleveland Clinic, which is where the study in blue was done, and that was right up until 2019. So we really haven't gotten better at this. So I want to walk you through a specific patient's example. This is a real patient. Her name is Not. And I was struck by her case when I was digging through some files for our research work. We'll call her Alice. She's a 31-year-old woman, and her mother was diagnosed with breast cancer at 41, which is a major red flag for hereditary cancer risk, both for the mother and for Alice herself. Based on current guidelines, genetic testing for risk stratification is indicated for both Alice and her mother, but neither of them have ever had it. We're going to come back to Alice. So we have this problem where there's a huge potential benefit and guideline recommendation that we risk stratify for cancer based on genetics, but it's just not being done. So how do we solve this? How do we support frontline care providers in actually making this feasible in their own practice? As I'll show you in the latter part of the webinar, they know this is important. They want to be doing this. So one possible solution is digital tools that support them in making these assessments and getting their patients the care that is indicated. So I'm going to walk you through one of our digital tools that helps with that and a little bit of our recent research on it. So our digital tool is called RISE, and we're specifically going to talk about the hereditary cancer risk assessment module. What do I mean by digital tool? This is something that is patient administered. Patients fill it out in their doctor's waiting room, or it can be sent to them in advance of their appointment. It's very brief. We have real-world data that it takes less than 5 minutes, and it is guideline-based. And coded into it are over 140 different combinations of medical and family history that can indicate, based on guidelines, that genetic testing is needed. So the first thing we did with this tool was to make sure that it was clinically valid. The gold standard right now is assessments made by cancer genetic counselors. We compared the assessments the tool made to assessments made by those counselors, and we saw 96% agreement in assessment. We actually expected the missing agreement because it's specific things that patients cannot report themselves, particulars of their pathology report that are not amenable to patient report with a digital tool like this, but can be picked up through the records. So a high level of clinical validity. So let's go back to Alice and her experience with this tool. So Alice walks into her OB's waiting room for an appointment. When she checks in, the front desk gives her a QR code and says, your doctor wants you to fill this out. It's related to your cancer risk. She scans the QR code and that pulls up the RISE Hereditary Cancer Risk Assessment module. She completes that, and as I mentioned before, guidelines say that she should have genetic testing, and that's what she is told based on her family history. One of the things that really struck me about Alice's experience was just how timely the care she received was, which, as many of you may know, there are often very long wait times for genetic services, sometimes all the way up to months, especially for someone like Alice who is currently not affected by cancer. So what we saw in Alice's case was it took her only 3 minutes to complete RISE and get that assessment. She was immediately able to schedule an appointment with one of our genetic counselors by telehealth. And then that appointment was only 4 days later instead of months later. So that's Alice's experience, but what about the experience of her OB? So her OB has been able to provide her this service that otherwise has not been feasible in terms of time or expertise for the OB's office to provide on their own. And then the OB also gets the documentation you see here on the screen that says that she had this assessment, that it's appropriate for her to consider genetic testing for hereditary cancer risk, what the history was she reported, and what aspects of her history indicate that she should have this genetic testing. So Alice is just one person, but we did study about 2,500 folks just like Alice who interacted with RISE in their OB's office. We wanted to get some sense of, is this really acceptable for patients? Is it feasible? And fortunately, we saw that 95% of individuals who interacted with the digital tool completed it. And they did so on average in 3.8 minutes. So it's acceptable, it's quick, it's something that can be done in the waiting room, and that patients are very likely to complete. And what did we find? In this cohort of 2,500 patients in OB offices, over a quarter of them needed genetic testing to risk stratify for hereditary cancer risk. And the vast majority of them had no personal history of cancer. So really, this is an opportunity for prevention and a population health intervention. I'm actually going to come back to a lot of this at the end of the talk when we talk about the provider professional well-being aspect of the Quadruple Aim. But for the next aims, I'm going to hand it over to Molly McGinnis.
This next section around enhancing patient experience, which is the second Quadruple Aim. So I think it's helpful for us to start off and talk a little bit about what we know in terms of the patient impact of genetic counseling. So the literature is small, but it's growing in terms of the inherent benefit to patients, both from a medical and psychological standpoint after they have access to genetic counseling services. From a medical perspective, we know that patients obviously have access to this expertise to provide a more accurate and thorough family history, which can really guide evidence-based recommendations in terms of appropriate testing and management guidelines. And then for patients who have access to genetic counseling after testing is completed, there is a growing body of literature showing a greater adherence to management recommendations. And this is really key when we think about patients accessing services. I paused there for a minute, but it's also based on the management recommendations that come. And then when it comes to psychological benefits, we know that there's a lot of psychological benefits after receiving genetic counseling. So patients making more informed choices, as well as studies showing lower distress and disease-specific anxiety. There's also a lot of publications using validated assessment tools showing greater patient empowerment, satisfaction, and engagement. So really some clear evidence that access to genetic counseling can improve the patient experience. But when we're talking about improving the patient experience, it's important for us to understand and recognize that not all of our patients have equal access to genomic services. We know that this is because of a number of geographic and socioeconomic reasons. But unfortunately, there's a lot of reasons why patients don't have access to genomic services, which may be because of perceived barriers from their physicians or their healthcare providers. We know that there's evidence showing that physicians may perceive patients not to be interested in services or be able to pay or access those services. So it's important for us to really recognize that these disparities in access is not just geographic. There's other discussions that have to occur. On the right hand of the screen, you can see really a depiction of distribution of genetic counselors across the US. Not surprisingly, you can see that they are really clustered in major metropolitan areas, meaning that these rural areas are much more underserved when it comes to accessing genetic counselors. So again, important for us to really understand who our patients are and where they're coming from so that we can develop tools that accurately and comprehensively can allow patients to access services. And so this is really where telehealth can come in. Obviously, all of us sitting on this phone call know the value of telehealth services, especially post-COVID, when a lot of our providers shifted to this service delivery model. But I think when we're thinking about telehealth, it's important for us to understand some of the misconceptions and perceived barriers that we can see. I think there's a couple of surprising statistics in this sheet here. We can see that the vast majority of Americans do actually have access to a smartphone, which really enables increased access to providers, especially when you have text to schedule and the ability to contact and do telemedicine appointments. But interestingly, we know that there's still a large amount of Americans that do not have access to broadband internet. And this can be because of financial reasons or just general service limitations. So again, another reason why it's important for us to understand where our patients are and how they are accessing services, because it really takes a kind of a multi-dimensional approach when we're thinking about telehealth and access. I think this is a great publication to share. This was a publication led by Wendy Ullman, who's a genetic counselor and researcher out of University of Michigan, who really comprehensively looked at how telehealth can provide equitable access to patients, really lowering that barrier and helping patients understand access to services. So again, it's not just about accessing services because of a lack of transportation issues or flexibility with work schedules. I think one thing to consider when we think about patients accessing genomic services is many of our patients may have significant health issues, especially patients who have a rare or undiagnosed genetic disease. This can make traveling to the clinic challenging if their condition impacts mobility, or based on psychological issues, it can make it really stressful. So the ability for patients to access services through video or through the phone in the comfort of their own home means that they can really better understand and take in the messages from the counselors and the physicians that they're meeting with. Another thing I'll point out about really the benefits of telehealth is this allows not only the patient to benefit, but really the extended family. So this can allow multiple family members who live in the same household or live close to sit in on a visit together to help that patient understand the impact of the genetic information and also potentially impact their understanding of their own inherent risk. So this enhanced communication can really help downstream opportunities for that family in terms of accessing care. Telehealth also offers the ability for enhanced family members to access services if they don't live in that geographic area. It's much easier to provide a phone number to a service that can provide telehealth services versus have that family member try to look up on the internet where they can access genetic services, especially if they live in a rural area. So again, a myriad of benefits when we think about telehealth service platforms. And this is really where Genome Medical comes in. As Steve mentioned, our goal as a company is to increase access, but also meet patients where they are. So we provide coverage across the US and Canada, and from a technology standpoint, offer a multitude of platforms. So whether or not that's text to chat, video, and phone platforms. Patients are able to schedule an appointment within a week, and appointments are able to be scheduled 7 days a week. So this enhanced flexibility really allows patients who have more challenging or less flexible work or home life situations. On top of that, we have interpretation services for over 200 languages and customer service line. Again, if there's challenges, our patients know how to access us so they can get the services that they need. And I'd like to end this section really with a case study because I think this provides some really nice context of how patients can access telehealth services and also how we partner with our own health systems. So this is a case study from a partnership that we have had with a large West Coast health system. Their goals were to enhance access to genetic services and really meet the growing demand within their cancer clinic. What we provided to this partner was telehealth pre and post-test genetic counseling, as well as the routine summary reports that we provide back to the physicians and the patients. In terms of timing and efficiency for patients accessing these services, there was an average of 32 days for the patient to complete the full risk assessment program. So this includes scheduling the appointment, pre-test, post-test, and having genetic counseling or genetic testing ordered. So drastically reduces the time to care as compared to what that clinic was previously seeing. In terms of the completion of genetic testing, I think this is a really commendable statistic. 97% of the patients who received genetic counseling and for which testing was recommended actually followed through and completed testing. Again, this is key in terms of making sure that patients follow through with those recommendations because that really is going to help guide their care from now on. And then in terms of patient satisfaction, we saw consistently high patient satisfaction pre and post delivery of telehealth. So again, a great statistic to really show that patients do perceive telehealth to be kind of efficient and comparable to a more traditional inpatient appointment. So now kind of shifting gears, moving from talking about patient satisfaction to kind of the financial benefits of genomics programs. And this is really around reducing cost. We know this can be kind of a challenging subject to talk about, but this is the reality when we're thinking about implementing new programs within health systems, really understanding how they might benefit in terms of cost reduction strategies. As Steve mentioned, there are numerous genomics indications where we have clear evidence showing how deployment of genomic testing early on and systematically can drive cost savings across a number of specialties. Hereditary cancer being the most common that people are familiar with. We know that if we treat cancer at an earlier stage compared to a later stage, we'll have a significant reduction in cost in terms of the treatment for that patient. When we layer on genetic testing or access to early risk assessment, we know that that kind of further decreases the risk. So for patients who are identified as BRCA positive and have early risk MRI and mammography screening, that can reduce the risk that they're identified with a later stage breast cancer by 70%. So again, real numbers showing that providing early access to hereditary cancer and at-risk patients can reduce overall cost of care. A more recent publication looking at renal disease patients was quite interesting as well, showing a significant cost reduction when genetic testing is performed early in the diagnostic process. And then lastly, there's been a lot of exciting evidence and case studies really showing the clinical and economic utility of deploying genomic testing in the inpatient setting, specifically NICU and PICU. There are some estimations of what this cost reduction looks like in terms of length of stay. That's the main driver. A recent publication really estimated what that might be and showed that health systems could decrease cost savings by almost $2 million just based on the NICU length of stay when genome sequencing is offered to a hypothetical 1 million member health plan with about 10,000 births per year. And again, this is just based on decreased length of stay. We know changes in management, shift to palliative care, and then reduction in surgeries can further drive this cost saving in the inpatient setting. Another way to think potentially about reduction of cost is around kind of the strategic use of outsourcing genomics programs. So we know that outsourcing can certainly be a common way that health systems think about reduction in cost. This is not something that is applicable to all health systems, but we do know, again, thinking of that map in where genetic counselors are accessible, that there are areas that health systems have a significant challenge in building and retaining a genomics workforce. What this means is they often end up with a significant backlog of patients, or they have staff fluctuation over time, which can really impact the care to their patients. So by coming in and partnering with a system that can provide outsourcing for genetic counseling and medical geneticist support, this can really help these health systems think about supporting these challenges and overall can reduce cost of care. So again, something that may not be applicable to all systems, but something to think about if you are in the position where retaining and building a genomics workforce has proven to be a challenging aspect. And then lastly, I'll end on kind of thinking about the other side of that financial coin. So it's not just about, reduction in cost. Certainly that is the third quadruple aim. But when we're thinking about kind of the impact from the financial standpoint, we also should think about what this looks like in terms of the optimization for downstream revenue or increased financial services. This is an example of how a health system might think about calculating downstream revenue in a situation where they're offering hereditary cancer screening. You have a total patient population where you might be offering screening to. Then you filter through and think about the numbers of patients who complete that screen, meet high-risk criteria. In the case of hereditary cancer, this would be NCCN guidelines. And then those patients who end up completing testing and actually have management recommendations. When we look at that ending list of patients who have increased management recommendations, this can actually provide an increased source of revenue to that health system, especially if those patients stay within that same health system. And what is this really based on? Again, based on guidelines, risk assessment tools, and medical policy coverages, the types of services that health systems might be able to recoup based on a patient population being screened for hereditary cancer are things like mammography, breast MRI, colonoscopy, or even prophylactic surgeries. So some of the work we've done internally to really help our partners estimate what this looks like has been within a hypothetical example of a health system who might screen about 10,000 women for risk of hereditary breast and ovarian cancer. This could be within a high-risk oncology center or something like a primary care screening center. Of those 10,000 women who are offered this risk assessment, we might estimate that about 1,500 will meet NCCN criteria for hereditary breast and ovarian cancer. If we are just offering testing for a really limited subsection of genes, BRCA1 and 2, we would then estimate that about 400 patients would be either positive for a genetic mutation or be negative, but be high risk enough that they are recommended to have increased screening and management. For this particular situation, we would estimate that this health system would recoup about $1.6 million in revenue per year for every 10,000 women screened. Again, there's a lot of kind of caveats and nuances to these economic models, but I think this shows that there is real opportunity for health systems to not just focus on reduction in cost, but also opportunity to increase downstream service revenue and financial gains, with the ultimate goal of really serving these patients and leading to better clinical outcomes. I'll now pass this back over to Colleen, who will walk through our fourth and final quadruple aim.
Thanks, Molly. So this is a topic that I'm incredibly passionate about, so much so that I'm actually working on a PhD on this topic, where we are examining meditation as an intervention to help with professional issues with professional well-being. But what we all know is that most of the fixes that we need, the interventions we need, are not at the individual level. They're really at the level of the healthcare system and the way care is provided. So we're going to talk a little bit about how some of what we've shared with you today may be able to improve the well-being of clinicians and retention of them at your institution. So this is a report that was put out by the National Academies in 2019. It was really bringing together experts from across a wide variety of disciplines to synthesize the quite large literature on clinician burnout and to map out a framework for what leads to burnout, to identify what the evidence says about what drives burnout and how we can intervene on burnout. Now, of course, this was already a well-known problem before the pandemic, but it has become much more important and severe and affecting far more clinicians in the last couple of years. So it's really, dire that we do something about this. I want to highlight the artwork that's on the cover of this report. I think it was a really beautiful, intentional choice. So this is actually a clinician artist who made this artwork to really capture the both insidious and extremely multifactorial nature of clinician burnout and its development. And I would not have the hubris to say that adding genomics care will in any way solve clinician burnout, but there are a few of these threads, a few of the things that lead to the build of poor professional well-being that it can potentially help impact in combination with other system-wide solutions. So we're going to be pulling from that report specifically to look at what how some of the things we've talked to you today relate to some of the findings in that report. What I'm sharing with you here is a very recent review. It came out just in the last couple of months, and it summarized a variety of research studies on primary care providers' perspectives of what I was speaking with you about earlier, which is risk stratification for cancer screening. And across all of these studies, it was clear that PCPs have very positive beliefs about this. They think it's important. They want it for their patients. But consistently, study after study, including very recent studies, they report a lot of barriers, low self-efficacy, not enough time. They're already so strapped for time that they don't have the knowledge, and they want this care to be supported by the right experts on the team. So this is sort of the flip side of that perspective, which is a quote from a clinician who we support with the risk assessment tool that I shared with you, where they really feel like they're providing better care for their patients, and thus they're able to deliver better value by adding in this risk stratification. So we sort of take these last couple slides together and then apply them to some of the findings from the evidence on the development of clinician burnout and kind of pick out the pieces that this sort of care might impact. Well, we know that one of the greatest drivers of stress and burnout for clinicians is the modern documentation burnout and time pressure. And we hear these PCPs saying, I don't have enough time to do this. So if we can help them, whether it's through digital tools or telehealth, because it doesn't have to be both, if we can help them to provide this care without taking time out of their already very tight visit with a patient, and we can provide them the documentation that can potentially help some small amount with these drivers of burnout. And then on the right in green, you see things that improve clinician well-being. And a lot of this centers around the things we've been talking with you today about, that they want to provide this care. They know it's important. It doesn't feel good to not provide care that you know you should provide and that is guideline driven. But they want to do it in a way that is efficient and optimized and has the right sort of division of labor. And that then in doing so, in feeling like they're providing high quality care, that can drive meaning and purpose in their work, and that can support their sense of professional well-being and their retention. So this is kind of, as someone who studies burnout for a living in clinicians and is very interested in how do we start to chip away at this epidemic? How do we start to not just have wellness trainings, but deliver care in a different way that will buffer against this very forceful phenomenon that's really ripping through our health systems? These are some of the ways that I see based on the genomics care that we've shared with you today and the particular ways of delivering that care in partnership with clinicians that might promote better professional well-being. I'm going to hand it back to Steve, who's going to close us out.
Yeah, great. Thanks, Colleen. So yeah, I'll tie things up, and then happily it looks like we're going to have some time for questions, and we've gotten quite a few. Please enter that question if you haven't yet. We'll hopefully get to it. So I hope we've really demonstrated, at least in a few examples, how well genomics and some of these new technologies do align with the Quadruple Aim. That really allows us to be proactive. It allows us to shift that value curve more towards the population-based, personalized care that was really conceived of at the same time as those aims, at least the triple aims. And that we're really now in the genomic medicine era. I mean, this will continue to grow, and progress will be made for many years to come, but it's not a when, or an if. It's really a now proposition we have, that genomics can shift our care to higher value. This is really driven by the technological innovations we spoke about, not just the sequencing and scientific innovations and discoveries, but also technologies that improve the patient experience, really streamline and facilitate the provider experience so that this can be added into their care without significant disruption. And the economics is benefited as well from the lower costs. I mean, the value equation tips more and more in favor of deploying this care when the cost for the sequencing itself, given that it's a database that can be carried with the patient for their whole life, that it can be accessed and used both for preventative and proactive care or for any indication that might arise, and will also benefit their families, really helps to drive that equation. And that's true for value-based systems or whether you're a fee-for-service-based system. And finally, we do face a workforce shortage in genetics and genomics, and this threatens to increase as the complexity and scope of genomics increases. But we have to work together to overcome these shortages, and they can be solved through flexible, scalable partnerships utilizing the technologies we talked about. So hopefully we've left enough time. I will turn it back to our moderator to address some questions. Thanks.
Great. Sorry about my camera shifting a little bit there. Let's go ahead and move on to the Q&A. Now, there's still time to submit your questions using the Q&A tab to the left of your screen. I see we have a lot of great questions already. We'll try to get to as many as possible. Let's begin. Regarding the risk assessment tool you mentioned, what's been the uptake for patients, especially older patients who are technologically challenged?
That's a great question. We do have to be really careful about the digital divide, the idea that the more we use digital health tools, we're going to make health inequities worse. And there's a specific concern out there about something called the gray digital divide, the idea that elderly individuals are less likely to use digital health tools or feel able to use them. And so we have been keeping an eye on this in our own data. And actually, in the cohort that I shared with you, 2,500-ish patients who use this digital tool in an OBGYN office, we actually saw the opposite of the common assumption, which is we saw a higher rate of completing the tool among those over 60. It was actually 100% compared to 95% across the entire cohort.
All right, thank you. Our next question. My leadership doesn't see genetics as a priority or really understand its value in driving better outcomes long term. What's your experience trying to convince the C-suite that this is important? What's the catalyst to get something started?
You can take that one,
Yeah, so
Molly, for sure.
I'll kind of jump in here, and then kind of Steve can add his thoughts as well. But I think this is often the biggest challenge, right? Is having leadership really understand what it takes to provide an investment in genomics. And so I think we really have to work with healthcare leadership for them to understand how a genomics program deployment would really fit all of these quadruple aims. So it's not just about kind of the impact on improved patient care, clinical outcomes, patient and provider benefits and satisfaction, but also, as we mentioned, kind of the financial implications. So really, how does this program align with the health system's strategic aims? And then how can a program be built in a way that's really fiscally responsible? And so it's probably a combination of maybe starting with a kind of small pilot program to start, where you get some kind of initial investment, you get some physician champions on your side, you start to see some clinical outcomes, and then you build from there. And so that's part of the work that our team can do and partner with partners, is understand how they really build a solid business case so they can start to invest and offer genomic services to their patient populations.
Yeah, I'll add a little to that. I think it's interesting that on both ends of a health system, spectrum, pressure kind of comes in different ways. From the providers on the ground, there's often pressure for services because they're required to meet some of these guidelines for either quality of care or other reasons, for their health center. So they're, trying to fill that gap and trying to advance the need for partnership to fill, some of the gaps there. From the leadership level, some of these economic arguments or data actually do tend to play pretty well. They understand the quadruple aim. They understand all of these financial pressures. It's not the highest thing on their list, especially during COVID, but the numbers do make sense. That's why we developed the ROI kind of algorithms, or tried to think through that, because we often hear from leadership that you can't really run a health system on savings. It'd be great if in 20 years we got cost savings overall from this technology, but we have workforce shortages and other things. But they do respond to the early, this will pay for itself through ROI. It's not a money loser, and it actually is the thing you want to be spending money on, or the things that you're supposed to be doing, this surveillance that will help feedback on your providers, knowing that they're going to provide their patients good care. So the incentives line well. And finally, I'll just add that we've had a surprising amount of interest from the C-suite in providing these services to their own employees, because if you're going to keep your employees, your workforce healthy and happy, how do you retain them? These services themselves, as part of hospital-wide employer programs, have actually been a hit, if you will, that employees like the benefit that they can use this. It's for them, and it helps them understand how they can service their own patients when they come around. So for all of those reasons, we've seen some success.
All right, thank you. Next question. You mentioned lack of physician awareness for genetics. How can genetics really become standard practice if the docs aren't involved?
Yeah, that's, I think I mentioned they're not always aware of genetics, even in their own field. They're certainly not always up to date on the most recent advancements and recommendations. I think more and more, though, even in any specialty, they're aware of some of the lowest hanging fruit, as I mentioned, and the desire to be able to provide that to their patients. And but they're, as Colleen discussed, they're overtaxed. They don't have the tools to do this. They really feel like they just need genetics to pick this up, but there's no genetics to send them to. So, when we can step in and really help them with that, we can also help educate them. We can provide some peer-to-peer support for some of our systems. We really see that once it's being provided, they, get the idea of how this is really benefiting their patients. It takes a few successes to really see how it can impact a family, how it can change the likelihood of successful therapy for some of these patients. And given the astonishing progress in the therapies that are being developed, all the way up to cures for some of these conditions that used to be, devastating or even lethal, it doesn't take long for them to kind of, see and catch fire with the whole thing. So.
All right, I'm going to ask this next question in two parts. First, what happens after the counseling session regarding documentation? Does the patient get a copy? Is it fed back to the physicians, etc.? And the second part, do you have a solution to close the gap in care relating to data sharing amongst a patient's variety of providers so that each provider has the access to the same information?
Anybody want me to take that?
Yeah,
Yeah,
take that.
I can take that. So, we do integrate with health systems. We do work with EHRs to create the integrations that can feed the documentation back so it appears in the EHR. We do not have a magic wand to make that happen as quickly as we would like. I think anybody who's worked with health systems and EHRs knows that this is a long process, but we have been successful. We are successful, but we wouldn't, many partners get involved with us, work with us, and we have ways to return the results in less fancy ways, but getting the documents back to the physicians and other care providers so they can take action is really crucial. The other thing that kind of feeds into that second question is the patients have access to this. We have our own portal, before that it's fed back to their own portal at their health system that they can log into anytime, access those records, access their genetic test results, and they can take them and be that conduit for themselves and educating patients so that they can, be active in their own care, making sure that the flaws in the interoperability between health systems doesn't prohibit, the highest level of care that they can get through genetics. I mean, one good example of that is pharmacogenomics, which is a very broad genetic test, which often doesn't have a lot of impact on the patient at that time, depending on the reason they got the test. But it can really be anytime they get any medication, it's a sort of an asset that they can take with them and present to the prescribing provider and make sure that there isn't going to be any adverse outcomes and that the therapy can be optimized. So we acknowledge the problem. We're working on it, that it continues.
All right, thank you. For the next question, many of our patients prefer to receive care directly from our providers, even if it's with a virtual appointment. It sounds like with this, we'd be giving up patient relationships, which could hurt our patient satisfaction scores. Can you comment on that?
Well, do you want to take that? I could also take that.
Yeah, I mean, I can certainly just kind of re-emphasize that, and Colleen can jump in. I mean, I think the case study that we presented, that is just one case study of one particular partnership. We have many other partnerships where we've seen the same patient satisfaction rates, either before a telehealth model was introduced and then post telehealth model was introduced. So within that specific case study, we saw absolutely no change to the patient satisfaction. And I think in this time period, post-COVID, where people are much more familiar with the telehealth model, we really try to integrate well with our health system partners to understand that there's kind of a seamless transition from their current genetic providers to our providers. So it feels like it's a seamless kind of consistent experience that they're receiving. Colleen, I don't know if you want to kind of add anything more from the clinical side in terms of patient satisfaction and what you've seen maybe potentially in the literature.
Yeah, the other perspective we didn't mention here is I also see patients in our services. And a really important thing for this question, I think, is the fact that we have many customers where their patients experience us as a provider at their institution. So, that in the business lingo, everything is white labeled. So when we introduce ourselves, when the documentation comes through, it's not as Genome Medical, it's as X Community Cancer Center. So that the patient associates the entire service, an entire patient experience, which has the high satisfaction rates that Molly mentioned, with the home institution. And thinking particularly about community cancer centers that I just mentioned, though this applies to others, is one of the challenges with genetics is because there isn't a good distribution of genetics experts geographically, is that a smaller health system or a community cancer center often fears the risk and experiences the real loss of patients when they have to go to a tertiary or quaternary center to get their genetics, and maybe they don't come back, right? So this is one way by outsourcing in a white labeled way the genetics care, that the patient doesn't go somewhere else and not come back. And that the patient experiences the entire service as actually being from the home institution, not from a separate org.
All right, well, this will be our final question. We had a lot of great questions today. We thank you for all of them. We couldn't get to them all, but we will try our best to get back to everyone who submitted them personally after this webinar is over. For our final question, with such wonderful progress, are we paying enough attention to how to communicate complex genetic information to patients? Much of this information is overwhelming and not understandable by lay people.
So maybe I'll start with that. And since Molly actually covered a little bit, maybe she could comment at the end, but as a physician who often works with genetic counselors in clinic, so I'm communicating with the patient and then the genetic counselor is there also. I personally depend on genetic counselors to help make sure that the information we're relaying to the patients is understandable and is explained at the appropriate level with the appropriate words. So that's what genetic counselors do. They're highly trained to do this. And they catch me saying things that I should have explained better. And they're there to be my safety net on that. So I think Molly showed the data on the benefit of genetic counseling in all of these. And I should add, for a lot of conditions, it's not actually required. It's just preferred if we can do it outside of pre-authorization for some tests that are required by providers. But it is a huge asset in this very thing. So that's a great question. I don't know if you had anything, Molly, to add to that.
Can I actually add something?
Yeah, no, I'll just kind of emphasize again, the literature, really is growing in terms of, the value of genetic counselor skills, people who are trained specifically to take complex information, really break it down and empower patients to make the best choices for themselves regarding testing or management recommendations. And I think some of the most interesting, literature recently is really also showing patient satisfaction with genetic counseling services, even after testing comes back and is potentially negative. Let's say in a rare disease patient population where they're really searching for an answer for why they might be having certain symptoms. And even if testing is negative and they're still back in that situation of not understanding the genetic etiology, they feel satisfied and benefits from the genetic counseling services. So I think that really shows you it's not just about the testing process, but it really is about kind of comprehensive support and care for patients. And ultimately, right, that's what we want to do and provide to patients. Even if they choose not to do a genetic test, we want them to be able to provide, the right information so they're making the right choices for themselves. And this can be whether or not we provide both pre and post-test genetic counseling services, or if it's a combination of us just providing pre-test or just coming in at the end. I think there's different models that we can support and work with our partners to best suit their patient population needs.
Yeah, I was just going to add that the other model that we support is with no genetic counseling. There are certainly tests where it's very much appropriate and feasible for a physician to order genetic testing, and we facilitate that. I know we've talked about genetic counseling a lot today, but in addition to the risk assessment digital tool I showed you, we have a companion education digital tool. It takes patients less than 7 minutes. They can choose additional information to make it up to 10 minutes, sort of a choose your own adventure. And that is designed very carefully by communication experts and genetic counselors to make sure that the information is understandable to lay people, including who will never see a genetic counselor. And what we're seeing in our early data is it does effectively increase knowledge. This one specifically for hereditary cancer genetic testing. Patients report a very high level of kind of satisfaction, helpfulness, ease of use. So, and then the last one I'll add on, I know we're slightly over time, is when patients see us for genetic counseling, we also want to help get their physician informed, because the physician's the one who's going to continue to have the conversations. So we're very careful about the clinical documentation that we feed back to the clinician, helping educate them, because they may never have seen this genetic disease before, so they can continue the conversation with the patient.
Well, thank you all. We are out of time here for today. Thank you to everyone for attending this fierce webinar and for submitting so many great questions. I'd like to thank our speakers for participating and Genome Medical for presenting today's webinar. The webinar has been recorded. You'll be able to access the recording within 24 hours using the same audience link that was sent to you earlier. Thank you all again for joining, and we look forward to seeing you for future events.